Good afternoon, and welcome to today's Diversity in Medicine lecture series. There is no commercial support. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually, you may enter your question in the chat. A link to the event survey will be shared at the end of the program. It is my pleasure to introduce Dr. David Inwards-Breland. He is from Southern California and attended UC San Diego for undergraduate, majoring in biology. He then attended the UC Berkeley School of Public Health and received his Master of Public Health. He went on to receive his MD from UC Davis School of Medicine. Dr. Inwards-Breland did his pediatric residency at UC San Francisco Benioff, East Bay, California. After completing his National Health Service Corps obligation in Albany, Georgia, he returned to California and worked as an attending at UC San Francisco Benioff, East Bay, working in the teen clinic. After 6 years of working as a general pediatrician, he then decided to enter a fellowship at UC San Francisco Benioff, San Francisco in adolescent medicine. Dr. Inwards-Breland was clinical director of the Division of Adolescent Medicine, Seattle Children's Hospital, and later founded and served as the medical director of the Seattle Children's Gender Clinic. He has received many awards, including Top Doctors, Award for Distinguished Service in Promoting Diversity at Seattle Children's Hospital, and Community Leader of the Year from the Greater Seattle Business Association. Transformational Leader Award from the UC Davis School of Medicine Alumni Association, and Astounding Alumni Award from the Black Student Union at UC San Diego. Dr. Inwards-Breland was the division chief of the Adolescent Medicine Division at Rady Children's Hospital, which he co-founded, and co-director of the Center of Gender Affirming Care and clinical professor at UC San Diego School of Medicine. He relocated to Atlanta, Georgia in November of 2022 and joined the Department of Pediatrics at Morehouse School of Medicine. Dr. Inwards-Breland's research interests include adolescent male health, depression, transgender youth, and marginalized youth. He now sits on the American Board of Pediatrics, sub-board on adolescent medicine, and is a medical mentor for the World Professional Association of Transgender Health for their global education initiative. In addition to medicine and all of these awards, Dr. Inwards-Breland enjoys the arts, singing, spending time with his husband and his daughter, and riding his Peloton. Join me in welcoming Dr. Inwards-Breland.
Hello, everybody. You know, when I got here, I said, "You're going to read all that? That's a lot." And usually when I send it out, I think that they're going to chop it up, but she read it all. So thank you so much for inviting me to come and speak to you today. I want to make a disclosure that what I'm going to talk about, I learned from my patients. I don't speak for them. I'm just relaying what I learned from them, okay? So I have nothing to disclose. This is Lucero. I have her up here because I did reach out to her and got permission to tell her story. She is a young lady who was the UC San Diego commencement speaker in 2018, which is my alma mater. What makes her unique is that she is a transgender female identified person. When she was young, she had selective mutism. She didn't want to hear her voice. Finally, some astute clinician was able to ask her, how she identifies, and she identified as female. And from then on, she says she's never stopped talking. What's nice is that she is actually now in medical school and is going to be the future clinician that she's always wanted to be. But Dr. Maya Angelou puts it very nicely. Nothing can dim the light that shines from within. So these are it's not showing up on here, by the way, so I have to turn this way. I'm going to examine the medical and psychosocial complexities of gender-expansive youth, apply best practices in the care of gender-expansive youth, and then develop a framework to advocate for them. So endless things are gendered, from gender reveal parties to the local toy aisle. So from my point of view, any child, whether they're assigned female or assigned male, should be able to play with any of those toys, but it's very gendered. Even toothpaste is gendered. Even toys that kids play with have some social roles or gender role connotations to them. And as I said, even toothpaste, I think everybody has the same teeth. So why does this matter? Well, it matters a lot, and hopefully that I'm able to tell you why that is. So gendering is very traumatic for transgender people, particularly adolescents. As you know, the brain is developing, continues to develop until age 26. And so any trauma can interfere with those vital connections in their brain. And so it really has a bigger impact on them. You know, from thinking about which restroom they're going to use, do they use their affirmed restroom and be yelled at, called names, etc., or do they use the restroom that was assigned at birth and possibly be victimized? And this thing right here, many of my patients would say this, that misgendering is violent. I did a study in 2016. It was a qualitative study, and really this study helped me start the Seattle Children's Gender Program. This person put it quite nicely. Your gender is like drinking water. When you drink water, it's not supposed to taste like anything, but when it tastes different, you notice. That is what being transgender is like when your water tastes different. Excuse me. So again, why is it important? Well, gender identity is a living, growing experience for all of us. And unfortunately and fortunately, there could be some cultural connotations or expectations for people who are born male at birth and who are assigned female at birth. And those expectations center around gender roles. So this is our society's way of categorizing what the different roles someone will have. So, for example, males are the breadwinners. They go to work, they come home. And then assigned females, they are homemakers or home goddesses, and they stay at home, but that's not always the case, okay? And then gender perception, it's our perception of someone's gender. So someone's gender identity that they want to give to us is called gender expression. But how we perceive them sometimes is how we perceive them. And so if their identity is one thing, but we perceive them as another gender, that's misgendering. And of course, we'd have to know what their gender is to not misgender them. But it's hard for adolescents particularly to constantly teach us and explain to us and take some of this, kind of macro and microaggressions when they're misgendered. And so really it's upon us to educate ourselves. And that's why I'm so glad you invited me, because I'm not going to talk about any of the medicine. I'm going to talk about practical things that you can do with someone who is transgender or non-binary embodied folks. So a little bit on the prevalence. The UCLA has the Williams Institute, and in 2022, they did a meta-analysis and they found that 0.5% of US adults identify as transgender or non-binary. And as far as youth 13 to 17, about 1.4% of them, which is about 300K individuals. I also before I talk about health disparities, I talk about protective factors that leads to resilience. So it's important for these young people to have a supportive, family, supportive schools, supportive providers, supportive institutions of health. And then, trans youth who are supported by their families have similar levels of anxiety and depression. There was a study by one of my colleagues out of University of Washington who had a cohort of prepubertal children who identified as transgender, and their age-matched cohort of siblings who were cisgender identified. And what she found was they had similar levels of anxiety, similar levels of depression, which was really low. It's not until they hit puberty and start to feel like their bodies does not match how they identify and get misgendered when mental health really kind of goes down the hill. So we also know that by affirming someone, we can reduce some of this psychosocial issues that occur, like depression, anxiety. There was a study that looked at if someone who's transgender and non-binary is called by their name that they go by or pronouns, it decreases rates of depression and suicidal behavior. So we also know that gender-affirming medical care can reduce mental health comorbidities. So some of the health disparities, I think, I'm preaching to the choir about these. We all know this, unfortunately, that transgender and non-binary youth are at higher rates of bullying, victimization, depression, substance use, eating disorders. So as an adolescent medicine doc, I have been trained to take care of eating disorders, and good thing, because the population that I take care of have a large rate of eating disorders. And then, this is staggering. More than 40% of transgender individuals have attempted suicide. That's too high. So why does this happen? Well, you all know about minority stress theory. You have, this identity, either gender, sexual, socioeconomic, racial, or have an intersectional identity where you hit many of these, okay? And then you have stigma that with some of these identifications. And then you have bias, prejudice, discrimination. That causes this minority stress. And this minority stress often leads to low self-esteem, depression, anxiety. And that can lead to other comorbidities, substance use, self-harm, suicide. But if we look at transgender-specific minority stress, so you have these distal stress factors and this proximal stress factor. So the distal stress factors tend to be gender-related discrimination, rejection from their parents or from their peers, victimization. And then proximal, that's within them. Sometimes you have internalized transphobia, negative expectations, and then gender identity concealment, meaning they're not out and they're keeping it in. That often leads to mental and physical health problems. And as I mentioned, this whole intersectionality, a lot of people don't realize that intersectionality can often look where you identify in one aspect, like I identify as a male. So I'm not as discriminated against as someone who identifies as female, but I'm also African American. And so I have less privilege in that sense. So it's very important to kind of think about intersectionality and those who have multiple intersectional identities. And those tend to be Black, Latino, Latinx, people of color. Rates of suicide, and this is recent data, rates of suicide increased for this population 40% between 2018 and 2021. And this data is also from the Trevor Project, and we could talk about what that is. But Trevor Project also looked at mental health in adolescents and young adults and found that they also had high rates of depression, suicide attempts, discrimination, and victimization. So this is just showing pictures of young people who had killed themselves. But also, we think about certain identities, certain intersectional identities, particularly trans women of color are being killed. And no one talks about that. And we need to talk about that and know that that's a risk. This is from the Trans Murder Monitoring Organization. And this is data from 2020, so October 2020 to September 2021. And it shows those identified as transgender, those who were murdered in the past year. 58% of them were known sex workers. Many of them were murdered on the streets or in their own home. The youngest was 13 years old. And many of them are people of color. And then if we look a little further down that minority stress pathway, other like substance use and, STDs, things like that. So this was from the CDC. And it looked at HIV prevalence among transgender women in 7 big cities, and from 2019 to 2020. And they found that these transgender embodied women, 42% of them had HIV. Okay? 62% of them were Black or African American, 35% were Hispanic or Latina, and 17% were white. So there's definitely unequal access, there's inequities in many aspects of care. So what is gender affirmation? Well, a lot of people, when people think of gender affirmation, they think of medication. That's important, but that's not the only thing, okay? There's social affirmation. So this is when, someone uses the pronouns they want to go by or the name that they want to go by, okay? And people accept that and call them by those names and pronouns. Then there's the psychosocial and psychological gender affirmation. That's where the felt gender is respected and validated. And that's super, super important when you are validated as for someone who you are, okay? And then oftentimes there's this resistance to internalized stigma and transphobia. And then, of course, there's the medical piece, which I'm not gonna go into, but then there's the legal piece where legal names may be changed or gender marker may be changed on the birth certificate. So the American Academy of Pediatrics put out a position paper that talked about that we as pediatricians, as physicians, need to affirm transgender and non-binary bodies, okay? And that means we need to have electronic medical records, billing systems, patient-centered notifications that is designed to, support and respect the asserted or the identity of people. Okay, and some ideas around that would be, what do your intake forms look like? Does it have M and F, or does it have a write-in? Could people write in their gender identity? What about your EMR banner? Is it something that is, proudly placed there so no one would make a mistake? They can call the patient by their name or their pronouns. ID bands, stickers, inclusive waiting rooms. That means having pictures of people that look like the patients that you see. I'm talking about all patients, and particularly transgender identified people. And then, restrooms, super important. We just talked about that. And maybe even practicing and using gender neutral language. And a lot of people, are hesitant, say, I can't use they in a sentence, but you can. Because, like, for example, Dr. Miller, they left their bag in the back, okay? That's using they, them. So you could easily use that. You could also use their name in the sentence, okay? That is a way to be gender neutral. So this is a case. So this is Josh, a 17-year-old assigned male at birth, person who presents for a well-teen visit. Dr. G comes in and introduces himself to Josh and his mom. and mom, excuse me. Dr. G clarified everyone's name and proceeded with the well visit history. After Dr. G gathered all necessary history, he asked the mom to step out to talk to Josh confidentially. During the heads or shades or whatever you guys use for your biocycle assessment for teens and adolescents, Josh discloses that they go by they, them pronouns and identify as a non-binary female person. Okay? They state mom knows but has lots of questions. When mom comes back in, she asks, did Josh share with you his non-binary identity? I thought he was just gay. What happened there? Anybody? Raise your hand.
Raise your hand.
What happened? There's many things that happened there.
We found out that the mom knows about Josh's identity.
Yeah. That happened. Yes.
And
what else?
it sounds like she isn't necessarily against it, but needs more education on it.
Yes. She is actually confusing gender identity and sexual orientation, which are two different things. I think this person had something.
Yeah, I was gonna say, even though she might be accepting of his new identity, that she's still misgendering them, and
Yes.
yes, and so just more education about that.
For sure. So awesome. There's a few more. So couple of things. The provider, I recommend, and we recommend that the provider, when they come into the room, they introduce themselves and give pronouns and maybe even ask everyone their pronouns. That kind of sets the stage. That person, that young person knows that, oh, maybe this is an affirming person, okay? I think that's super, super important. And then mom is confusing the sexual orientation with gender identity. And mom is assuming based on lack of knowledge, just like that. And I think it's a great opportunity to educate families, patients about the difference between gender identity and sexual orientation. And mom is probably well-meaning. She just doesn't know. Even Josh said they have lots of questions, okay? The other thing is during that confidential, session, the provider should have clarified what he can talk about to mom, okay? Because there are times when the young person is open, honest, but they don't want to have their parents misgender them or have an argument start between the provider and the patient, that kind of thing. And so they should have clarified what they could talk about. Okay, so that's super, super important. There are patients that say, yeah, just don't bring it up. I just want to get through this visit and move on. Okay, that's looking at the difference between sexual orientation. So sex, what is sex? Well, it's based on chromosomes, internal reproductive organs, and genitalia, okay? What is gender? Well, we talked about this living, breathing thing. It's social, cultural, and psychological condition aspect of being feminine, masculine, both, neither, or somewhere in between. And it could be binary or non-binary. And then binary is someone who is, black or white, male, female. Well, someone who's non-binary may be gender fluid, may be, non-binary feminine or non-binary female, but has aspects of both gender identities. And sexual orientation, I love this. This is developed from transgender youth, and this really sums it up. And I often tell this to my patients' parents. Sexual orientation is who I'm attracted to, okay? The sex is the bits that I have, okay, that I'm born with. And then gender identity is if I'm a guy, girl, someone else. Those are the differences. I'm not going to go over this in detail, but as you know, sexual orientation, there's a spectrum of identities, okay, of sexual orientations. But there is for gender identity. There is a spectrum. Now, I've asked my patients numerous times, do you expect me as your doctor, to know all these? And they say, no, I just need you to know my identity or their identity, which makes sense. So they don't want you to know all these. They want you to be familiar with it, be open to them, that there's these different spectrum of gender identity. And if you want to learn more about them, there's a great website that kind of goes over each one in detail. So we talked about gender. We also talked about gender identity, and I mentioned gender expression. So, I have a buttoned-up shirt, slacks, pants, chinos. That in our society is more masculine. Now, if I came here with a great-looking skirt, with heels, in our society that would be more feminine expression. But that's their expression. You have to ask them what their gender identity is, and I have some examples. So this individual, if you look at them, short hair, maybe no makeup, collared shirt, blazer, they're more masculine appearing in our society. Whereas this fabulous person, is more feminine appearing, okay? I do not know their gender identity because I have not talked to them personally. But my perception is that they're more feminine or more masculine appearing. So names and pronouns. Atticus, dead name, and we'll talk about what dead name means, is a 15-year-old assigned female at birth, affirmed male, goes by he, him pronouns. He comes in with his dad to discuss menstrual suppression before he goes on testosterone. He and his dad check in at the front desk, and the front desk person identifies in the chart that the patient goes by Atticus. After checking him in and affirming his name, he is asked to sit in the waiting room to be called. The medical assistant comes to the door and calls out, "Beth, Beth." The waiting room is silent. What happened there? Anyone? Anyone?
Their dead name was used and they weren't, that's not their affirmed name at all. So
Yeah.
by medical staff.
Correct. What do you think happened? Why wasn't it used? Any thoughts? Yeah, maybe communication, okay? Maybe there was a communication, but look back. The front desk person was able to find out that they go by Atticus and probably had, documented, name or pronoun in the medical record. So this MA either wasn't communicated on how to find this information, or, there are sometimes people do not want to call someone by the name and the pronouns that they go by. So that can definitely happen, okay? And the patient probably had a lot of gender dysphoria because Beth is not their name anymore. It's actually Atticus. And I think this could be that lack of communication, or maybe the paperwork that the MA had did not have that information on it, and it was an innocent, mistake. But that innocent mistake could lead to Atticus and their dad leaving and never coming back because they did not feel affirmed. So what is dead name? Well, dead names tend to be their legal name, okay? And why is that a problem? Well, most legal names are gendered. Beth, John, they're gendered. And so that can cause a lot of gender dysphoria, okay? So pronouns and names. One thing that is printed and some people often say is preferred name or preferred pronouns. Well, I've had numerous patients say, stop the preferred. My name is, and my pronouns are, okay? So by saying preferred, it's like they're choosing to actually do this. Like people will say he, him to me. I'm not correcting them because that's how I identify, okay? But that's not how some people identify. It's not a preferred process. Please don't ever say, what is your real name, okay? Again, that kind of points to somebody just arbitrarily changing their name. It may seem like it, but it's not. That's how they identify. And use they as much as possible. We talked about that. We gave an example. And when to use, all the time. Now, a question that often comes up, if you're in with a young person, a minor, and a parent is misgendering them, how do you handle that? Well, couple of ways. You can say, hey, I see here, if everybody knows, I see here that XY goes by he, him, or she, they. I'm going to use that in my terminology. And most parents are like, okay, fine. I just can't use it because I don't know how to do that. Okay? But if the parent is adamant that you don't use the name that they want to be known as and the pronouns, you could use they, them, your child, your teen, okay? Which is very gender neutral. So labels and no labels. Chad is a 17-year-old assigned female at birth, affirmed demi-boy and male, and you could look at that website to find out what that means. They go by they, them pronouns, comes in for their college physical. Chad discloses to his provider that they plan to be stealth around their gender and identify as a man. How do you respond? What if they want to be known as a gay man? What if they want to be fluid and not label themselves? So let's take a step back. Stealth means, someone who is identified from society as their gender expression and their identity is perceived by society as what they identify. So it's going through society, their asserted or their affirmed gender. Okay, so what do you say? The thing is, labels and no labels. It's really up to the patient. So there's a couple of ways that you can respond. Chad, it's up to you to know how you want to identify and label yourself. And this can change as you see fit, and deciding when and where that would occur. Or you can say, Chad, it's okay to label or not label yourself. This is up to you, and any decision is your decision and not others. Unfortunately, this may not avoid misgendering, so you may want to decide how you respond if someone or some groups get it wrong. Your label is yours and yours alone. So, there are people, I'm going to be, use myself as an example. If I am in a group of men, I don't do sports, but I will go along with sports. It's just not my thing, but I will go along. I go in front of I identify as a gay man, and I go in with my gay friends, and we, kiki it up. It's a little different, okay? So I have different labels. I have different identities when I go in there, and that's what this is. You can choose, but I think talking about safety is super, super important. So labels. In 2019, the National Survey on LGBT Youth Mental Health, they identified greater than 1,000 sexual orientations and greater than, 100 sexual orientation and greater than 100 gender identities. Again, you're not going to know, all of them. I think what you need to know is the gender identity, the sexual orientation that with the patient that's in front of you. And avoid, invalidating if unfamiliar. That's okay. You can, if you're not familiar with something and you want to know, I think it's okay. It's definitely okay to ask. Okay, and it's okay not to label yourself. So sexuality. Carissa is a 16-year-old assigned male at birth, affirmed female. She and her pronouns. During her heads or shades assessment, she reports having 2 sexual partners in the last 2 years. And her current partner, Josh, they have been together for 6 months. You educate Carissa about safe sex practices and stress the need for condom use with anal sex because of the high risk of HIV. So what happened there? What's missing? I'm going to tell you there's some assumptions that occurred. Right there.
So it looks like there was an assumption made about the type of sex that they engage in.
Yes, yes. Their sexual behaviors. How are they using their body? What parts of their body and their partner's bodies are being used in sexual, activity? That's super, super important. What else is? We talked about behaviors. So we're assuming that Carissa is having anal intercourse. Oh, I'm sorry. I stole your thunder.
No, they're also assuming Josh's gender.
Yes, assuming Josh's gender. Josh could be assigned male at birth, assigned female at birth. We don't know. Okay, and that's why it's super, super important to really not focus on sexual orientation per se when knowing how to screen somebody. Is their actual behaviors, the types of sex that they're having. Okay, and that's just assuming that HIV is prevalent in this population, but it's assuming that she is at high risk, and she may not be. Okay, so excellent. So also, hopefully you've had a lecture on trauma-informed care. I think it's super, super important that trauma-informed history and exam be really thought about. When you think about a young person as they go through puberty, their body is changing, and it may be changing in the wrong direction. And it causes a lot of embarrassment, trauma, that goes along with not having the body that matches their gender identity. And so, it's very important that you treat patients, particularly these patients, with a trauma-informed lens. And so there's a few things that I think are important in this case. Before you talk about or do the exam, you talk about nomenclature. What do they call their different body parts? Okay? Do they call, someone who's assigned female at birth, do they call their breasts, or do they call them chests? Do they call different body parts that tend to be gender different things? A lot of times they say, just go in and call them by the medical term. Okay, but you should ask. And then while you're doing the exam, you need to explain, sometimes we have a busy clinic, we're trying to, catch up, and I got to do a physical exam. Well, take maybe a minute to explain why you're doing the exam. Why is it important? Because I think they deserve to know. I think all patients deserve to know. Okay? And ask for permission, meaning, there's a high rate of victimization in this population. There is. And so, having someone touch their body can be show a form of violence to them. And so asking for permission, like for example, I always, when I'm going back in back of a patient, I don't care who they are, I ask for permission. I say, is it okay if I listen to your back and listen to your lungs? Quick, is very quick, because that could be, that can avoid someone who you touch their back and they startle. That just re-traumatizes them, okay? And don't rush. Rushing, we often make mistakes. And when we rush, sometimes we misgender, okay? And this is a picture that is a stock picture of folks who are transgender, but it shows you a couple of things. It shows you that the provider is talking to the patient, probably telling the patient about either taking a history or telling the patient about, what the plan is, but they're in a gown. And they already probably have a body that they don't feel comfortable with. And so just imagine how much of the history or the plan is actually getting in when somebody is traumatized because they're in a gown, okay? So definitely read the room. Take a minute and say, hey, is something going wrong? Can we stop here and pause? totally okay, because I think that will actually make the visit go by a little smoother. Mistakes. So Nelson is a 16-year-old assigned female at birth, affirmed gender fluid person. They go by they, he pronouns. Comes into the office to discuss the COVID vaccine. While speaking to Nelson, you use their dead name, June, twice, and use she pronouns once. So what should you do? So this happens. This happens to me. You know, it happens. We are human, but the key is to not keep doing it, okay? So what we should do is we apologize. Once we catch ourselves, we apologize and move on. People don't want you to dwell upon something, because when you dwell upon, oh, I'm so sorry, oh my God, how could I do that? That's placating you and not the patient, because they just want you to move on to the next part of the exam or the history. And the key really is to listen to your patients. If they correct you, take that. It's okay that we as clinicians get corrected, okay? Because it's really cultural humility. We don't know everything. And so listen to our patients and be accountable. Apologize, move on, and try to not do that again. And maybe practice, your gender neutral language. Screening and safety. So Chad, they, them, has come back with their girlfriend, Sasha, who is assigned male at birth, goes by she, her pronouns. Because they felt affirmed, they had questions about binding and future top surgery. She has questions about tucking. How would you counsel them? So the next set of slides are graphic, but I think you need to see these things so you'll know what they are, okay? So screening and safety. So when we think about someone who is more masculine identified or embodied, we do have to take a menstrual history. I often don't say menses. I often just automatically say bleeding every month, okay? Or I find out what they're saying. Are they binding to have the appearance of having a flat chest? How long are they doing it with exercise? I think that's very important information. Although we don't have any evidence on proper, wearing of binders. Hopefully that's coming in the next couple of years. What are packers? Trans feminine, what is tucking, and how they do it, and how long. And then, because of the history, we have disordered eating behaviors, we have mental health concerns. So screening for mental health is important. Screening for substance use, sexual behaviors. Look at bullying and look at cyberbullying, because back when I was young, I could get away from the bullying. But if I get away from bullying and then I go online and I'm bullied again, it's a lot worse, okay? And how supportive of their friends and family is super important. So these are the graphic things. So top left, those are trans tape. It's tape that doesn't have, has adhesive, but it doesn't, bother the skin. It doesn't break the skin out as much, and usually it's temporary. And as you can see, it just makes it flatter. It doesn't make it all the way flat. You probably need something like a binder. But I've had patients use these who, trans masculine patients who are on the swim team, and they wear this under their bathing suit, okay? Here are packers, and these are silicone devices that they put in their underwear to have the illusion that there's a bulge or they have a penis. Okay? Here, these are stand-to-pee devices, okay? These are placed over the urethra in the vulva, okay? And it allows them to use the restroom of their choice, particularly if they want to use a men's restroom that has a urinal, okay? And then these are binders. These also causes the appearance of having a flat chest. When I first started this care over 10 years ago, that's what they looked like. But now we have a little bit more diversity, which is awesome. So this person is a speech pathologist, and speech pathologists are awesome. They can help a trans feminine or trans masculine person either increase the pitch of their voice or lower the pitch of their voice, and safely. And so they are there. I know we have a few at Children's Healthcare of Atlanta. Tucking. So in the past, people would tuck by taking their testes or gonads. I sometimes say gonads. They often laugh, like, what is that? But they actually tuck it in the inguinal canal, okay? And either the penis is held close to the body or between the legs, and sometimes they use this trans tape. But there's another way. There's these panties or these underwear that's called gaffs. And gaffs have an embossed front that actually pushes things closer to the body. And so you don't necessarily have to put the testes in the inguinal canal. Why is this important? Well, sometimes people who put it in the inguinal canal and use trans tape, they avoid using the restroom because they don't want to untuck. Okay. Whereas if they have a gaff, they could, use the restroom and then they can tuck with the gaff. Hair. For our feminine patients, hair can be an issue. There's electrolysis, there's laser hair removal, often not covered by insurance, but I think knowing that those are options for them is important, particularly around electrolysis. With electrolysis, you have to have darkly pigmented hair. So it doesn't really work well on lightly pigmented hair. So that's something, tidbit that I don't know if you know, but that's important to talk to patients about. And then laser hair removal. So I'm going to talk in the last few minutes about best practices. So disclosure. So telling someone's story. When I first started my talk, I told you that I asked for permission from Lucero to tell her story. If she didn't give me permission, you would not know about Lucero because that's not my story to tell, that's hers. So that translates into, your patients. You should not be really talking to other, colleagues or, staff. If it's not directly medical or related to their care, you don't need to tell their story. Okay. Transitioning. Transitioning is a hard word. Someone will find out someone's transgender or non-binary, and you just assume that they've transitioned. Well, what does that mean? Not everybody can afford or have access to medical care and medical hormones, things like electrolysis. So we should not assume that someone has transitioned unless we ask them, okay? What's the right age? As a pediatrician, most of my 3 and 4-year-olds know that they are a boy or a girl. Now, oftentimes that is from their parents or the school or their environment telling them a boy or girl, okay? Sometimes it's innate, but they know they are a boy or girl. So talking to people, parents and young people about gender, early, I think it normalizes it that it is normal, okay? And then binary and non-binary genders. There are people who are assigned female or assigned male at birth who identify as strictly male, strictly female, not trans male, not feminine, but male and female. So there are people who identify binarily as their gender. And we talked about this, sexual identity is different from gender identity, and sometimes it gets confused. And by clearing that up, people can really focus on understanding gender identity. Passing. This is another problematic word. Many of my patients say, we don't like people say that we're passing. It feels like we're trying to trick people. We're passing. Okay, a term that they often use is stealth. Okay, misgendering. It could be deeply hurtful. Even though it's innocently done, it could be deeply hurtful. And so the key is try to avoid it at all costs if you can. Make the electronic medical record, gender friendly, gender neutral friendly, and your language more gender friendly. Telling someone you don't look trans, believe it or not, this happens a lot. And it could be well-meaning, but it's really a derogatory statement, really, to transgender and non-binary individuals. And keep it relevant. If it doesn't directly relate to your care of that patient, you don't need to ask them. Don't probe into things that really don't relate unless the patient wants you to talk about it or they want to talk about it. And we talked about, unsupportive parents. And my rule of thumb is try to use gender neutral language and move on, because having a not an argument, but a back and forth with a parent is going to be right, okay? And because that parent may take that child away from your care. The key is to keep them in a safe and affirming environment. And just briefly, there's anti-transgender legislation, and this is from the transgender non-binary youth. It makes me angry and upset, and not very optimistic for the future of trans people. Makes me sad and scared for the future. As a transgender man, it has made me very sad and scared for my safety. They have caused me great anxiety. It has made me feel increasingly trapped and hopeless. And I think most importantly, a lot of patients don't feel safe. I don't feel safe. I feel like some enigma that people would rather not have around in society, like it will harm them in some way or somehow. Advocacy, just briefly, there's advocacy. There's advocacy and there's activism, and there's a difference. And so what I'm doing is I'm informing people about how I learn from patients. I'm calling on others to take action. I'm doing research. I'm writing about it. I have done some overlap with activism, meaning I sent letters to politicians, etc. So kind of knowing the difference. So lastly, ask how you can support and be open to negative feedback. Educate yourself and families, and add to anticipatory guidance a discussion about gender. Take the patient's gender identity and expression seriously. Acknowledge the mistakes and own them, and try to do better. Respect the patient's name and pronoun. Communicate this with staff and update forms. Communicate it to staff if it's very important to not misgender patients. Remember to always refer to transgender and non-binary persons by their name and pronouns, even if they're not there, if you have to talk about them. And do not out anyone. There has been cases where there's been assault of patients as they left clinic because they were outed by a staff or the doctor, etc. So do not out them without their permission. And really having resources and support. And there's probably many other suggestions out there. I have resources. I'd be happy to give you this talk. There's resources out there that I think are particularly good. The Human Rights Campaign has one. Actually, Parents for Transgender Equality Council is awesome. Trans Families is a great group for parents who are needing support from other parents who have transgender youth. And the HRC has something called Welcoming Schools. This is a way for you to help schools become more affirming. PFLAG, Parents and Families of Lesbians and Gays, is awesome. They are an amazing organization and have a lot of great resources. Okay. Thank you so much. I really appreciate your time.
Doctor, thank you so much for that discussion.
Thank you.
Really important. And so my question is about some discussion in the public about the right age, and you mentioned it briefly. And so as someone who would want to provide gender-affirming care in the future, I ask, how do you respond to that? What is your response to the public when they say, kids can't make a good decision about their gender, and it might be something that they regret?
Great question. So I often say, gender identity is something that we all go through as far as our development. Like, my gender identity is male, so are you saying that I shouldn't say I'm a male person because I don't know yet at 12, 13, 3, 4 years of age? It just doesn't, kind of make sense. So, I think that times like that, I say, I get you. Can I give you some resources? Can I give you some information to look at? And really, because a lot of times it's a lack of knowledge. And by giving them the knowledge, it gives them a little bit more information. And then they may not change their mind, but as far as you are concerned, you have a lot of data, you have a lot of research behind you and backing you up that this is something that we should do. It is backed by many, many medical organizations. So a medical organization would not condone something that is not something that we should not do. So, it varies on the person, but I give resources and I talk about how it's important. Great question.
Thank you.
The other thing, I want to put a plug in for the Fenway Institute in Boston. They have a lot of free educational resources that are awesome. So definitely look at those. UCSF is a center of excellence. They also have great resources. There's quite a few. I'm sure Dr. Bondmiller can also share some of the resources that she has. Well, thank you so much.
Thank you very much.
Thank you.